Let's go ahead and move the first bill on the agenda. Madam Vice Chair.
Mr. Chair, I move that Senate Bill 1600 be returned with a due pass recommendation.
Thank you. Okay, Justin.
Yes, Mr. Chair, members, Senate Bill 1600 makes various changes to the statutory duties owed by medical professionals under current law to provide abortions to promote, preserve, and maintain the life of the fetus or embryo who is born alive. Specifically, the bill entitles an infant who is born alive to be treated as a legal person under Arizona law with the same rights to medically appropriate and reasonable care and treatment, and requires healthcare professionals to take all medically appropriate actions to preserve the life and health of the infant who is born alive, among other new and existing requirements. The bill also classifies a health professional's intentional or knowing violation of certain of these requirements as a Class 6 felony, and also gives rise to professional liability and civil liability for damages in certain circumstances. And with that, Mr. Chair, happy to answer any questions.
Thank you. Members, are there any questions for Justin at this time? Okay. The Senate is still on the floor. They're still working. They can't get their stuff done in time, so we'll just move right through them.
Okay.
The sponsor's not here is what I meant.
Right.
So let's go ahead and go into who we have signed in to speak.
Our first one that we have is Lance Holman. Lance Holman.
Lance. And for those of you listening, that was my attempt at dry humor, so. Pretty bad at it. It's a very dry response.
Oh, my God.
All right.
Mr. Chairman and members of the committee, good afternoon. I'm Dr. Lance Holman, and I'm a board-certified OBGYN. And I want to share with you the story of a patient of mine that I hope will illustrate the need for you to support Senate Bill 1600. In the summer of 1987, I was the OB for a young woman. Her pregnancy was completely normal until approximately 24 to 25 weeks, at which time she developed increasingly severe pregnancy-induced hypertension, which is also known as preeclampsia or toxemia of pregnancy. She eventually required hospitalization as her condition continued to worsen. She developed kidney failure, blood clotting abnormalities, and we ultimately got to the point where if we did not deliver the mother, we were going to lose both mother and baby. The cure for her was the delivery, but at this time, 35 years ago, the chances for this baby to survive were practically zero. And we all knew that, and yet the decision to deliver the mother had to be made. We did her cesarean section. The neonatal staff, the nursery personnel were present in the operating room, and I handed the baby to the nursery staff, who immediately took over the care of the baby. The mom slowly but surely and completely recovered, and miraculously so did the baby, ultimately getting to go home, thus beating all of the odds and the statistics that we had at that time. What is my point? The point is that our care for preterm babies in 1987 was state of the art, but the care that we have available to us today for these babies is infinitely better. Yesterday's 27-week baby is now a 23 or a 24-week pregnancy baby. The care that saved this baby's life was not the care that I gave. It was the care that was given to this baby by the neonatal intensive care doctors and nurses and people that took care of this baby. When an abortion is done, usually it's an OB, maybe it's an emergency room doctor, maybe it's a family doctor. They are the ones performing they are the ones that are performing the abortion, and none of us outside of a neonatologist are trained to identify and be able to provide the care that is necessary for these babies. These are the people that have to be available at the time of the delivery, and so that they can identify and manage the problems. On another note, we do a lot of talking about genetic testing, and genetic testing gives us a diagnosis. But genetic testing does not tell us anything about the severity of the condition that we have just diagnosed. A genetic abnormality can range from here to here in terms of its severity. And when we're sitting here prenatally, antenatally, before the baby is born, All we have is this diagnosis. We don't have any idea as to the severity. With timely and appropriate care, some of these babies will live. With no care, every one of these babies is going to die. I feel that they all deserve the best chance of life that we can give them, and I ask you to support this bill.
Thank you. Members, any questions at this time? Representative Shaw.
Thank you, Mr. Chair, Doctor. I guess I have a couple issues with a couple parts of your testimony. First of all, I am an emergency physician and I'm board certified, and nowhere in my training anywhere is there any mention of abortion in my specialty. So you mentioned that as part of your testimony, and I'm not sure that's accurate. Do you want to rephrase?
Well,
Mr. Holman.
Mr. Chairman and members of the committee, I don't know who does abortions. Most abortions that I know of, most abortionists that I know are OBs. I can't say to you as a committee that every abortion is done only by OBs. I would agree with you. I mean, the emergency room docs that I know, do 1 or 2 months of OB so that you can deliver a baby if mom delivers before I can get there. But my point there is, whether it's a family doc, an emergency doc, an OB, none of us are trained. I'm sure that you spent some time in the neonatal intensive care unit just like I did, but neither one of us are neonatologists. Neither one of us are really trained or qualified to identify what does this baby need and then provide it for that baby.
And
So I'm sorry if I misled. I did not intend to.
Thank you. And Mr. Chair, thank you for clearing that up. And the second part of it is that the bill at hand and the issue that, so as a physician who has sometimes been in this exact type of position, will tell you that when we have a delivery happening, right, and that person is obviously in a very difficult spot if it's a very preterm infant, right? Now we're at a place where we are trying to take that situation and trying to honor the wishes of the family at the time when a very difficult situation is happening. So of course, I'm sure you've practiced medicine for a long time, just like I have, but the bill at hand ties the hands of physicians at the time that they are in such a harrowing spot and takes away clinical judgment. That's the part of the bill I can't agree with. And that's what I want you to more address, because I think you and I both know we've been in difficult situations. And to have an overarching state statute say, look, doctors just simply have to do something in perhaps a medically futile situation, that's the part that from a practicing physician doesn't seem to make a lot of sense. If you could comment on that.
Mr. Chairman and members of the committee, thank you again for the opportunity to be here. Again, I understand completely what you're saying about futile. I guess my point is that unless we are trained to know what is futile, can't we just give the baby the benefit of the doubt? I mean, if the baby is truly going to die, nothing that you and I can do for that baby is going to save it. We may save it for 15 minutes, we may save it for an hour, we may save it for a day, but doing the best that we can do under the circumstances at least maybe buys us some time in some circumstances. To do nothing, to take a preterm newborn baby and set it on a cold metal tray and say, in my opinion, as someone not qualified to make an opinion, not knowing what's available for this baby, not knowing the ultimate outcome for this baby, I'm going to set this baby over here on a cold metal tray and we're going to all watch it suffocate to death. To me, that just seems barbaric and inhumane, and it goes against the oath that you and I took to take care of patients. As an OB, I have 2 patients. I have mom and I have baby. And until I turn that baby over to somebody who is more qualified than I am to take care of that baby, I feel like it's my duty and my responsibility. And if nothing more than just my humanity to do whatever I can do for that baby, rather than saying, I don't know what's going to happen, but in my mind, this baby is not going to make it, so let's just set it over here and do nothing for it.
Thank you, Mr. Chair. I'll save the rest of my comments for later.
Okay, I have a to that point, question by Representative Parker.
Yeah, thank you, Mr. Chairman. And to that point of Dr. Shaw and Dr. Holman is, I understood the way he had experienced that it was kind of a DNR. We never have a DNR on any patient unless that's already been decided ahead of time. So a brand new baby, we're not going to have a do not resuscitate. So that emergency decision, as you're recommending in that moment, is not made at that point. Once the baby's born alive, or any patient without a DNR, we would automatically institute all emergency procedures in healthcare. It would be done that way in the emergency room. It would be done that way by paramedics. It would certainly be done with a newborn. Am I right?
Mr. Chairman and members of the committee, yes.
Mr. Chair.
Okay.
So to that point, I want to respectfully add that in such cases, while we do not fill out DNRs as paperwork in advance, we do consult with family members and make a decision with everybody all speaking to one another, explaining risks and benefits and consequences of our actions. And the problem is that when you put that into statute as saying there's an overarching statute above that conversation that's happening, that puts medical providers, patients, and everybody else at odds with one another because there is now a potential legal problem with a statute that's hanging over your head. And so to me, and when sometimes some of these end-of-life decisions happen, not just with babies, with others, you will see that doctors will go out and make sure the patient, family, and others are involved in the decisions. But the statute on top of it, the law, the force of the law applied, is where the problem is that we're having with this. So thank you. I appreciate you listening.
I have a question by Representative Grass.
Thank you, Mr. Chairman, Dr. Holloman. I do want to bring this conversation back to the implications of this bill. And I think you briefly touched on it. I understand we had a conversation about legal statutes and all of these constructs, but can you help us better understand what's really at stake here? What is happening to this baby when he or she's left untreated?
Well, Mr. Chairman and members of the committee, thank you for that question. If we are talking about a preterm baby, which most of the time we are, the last organ system of the baby to develop is going to be the baby's lungs. And so if we do nothing, if this baby is born at 23, 24, 25, 26 weeks of gestation, it's going to have immature lungs. It is not going to have the ability to breathe on its own, and is therefore, if we set it over here on a table and do nothing for it, this baby is going to suffocate, basically. Now, there may be other things going on. The baby may have cardiovascular abnormalities. The baby may have other, intestinal abnormalities. There may be other pieces to the puzzle that can be identified and sometimes fixed, and maybe sometimes not fixed. But the ultimate first priority is going to be to breathe for the baby.
Mr.
Representative.
Chair, and
Okay.
to that point, I just want to add that I said it before, I'll say it again. I've been in this situation personally, and every single time that those parents who are grieving a loss have been given the opportunity to comfort the child or that second patient, have been given a chance to sort of spend time, just like we do with perhaps sick and dying patients at other ages. They've been given a chance to make that decision and then say, what do I want to do? And if this is what we want to do, is spend time with our child. The idea of a cold metal tray, to me, doesn't make a lot of sense, because that hasn't been my clinical practical experience.
Representative Parker, do you have?
Yes. Dr. Holman, and kind of to the point, a question I have for you. What Dr. Shaw is raising is the question of the family's ability to make, or decision to make, that ethical decision at the moment of birth. I think the statute, if it's pretty clearly written, if you'll look at page 4, line 23, any health professional who is present at the time the infant is born alive shall take all medically appropriate and reasonable actions to preserve the life, even if that child is not likely to survive, line 26. So, again, it's about reasonable actions when the child is born alive, regardless, is if they will survive, which would also fit with, you know, the situation I think Dr. Shaw is talking. I think the law is pretty clear. You're giving reasonable treatment, regardless of that child's ability to live after that reasonable treatment is given. Would you say that's correct and pretty clear?
Mr. Chairman and members of the committee, yes, that's why I'm here.
Yeah, and I think that's what the statute is saying. Thank you, Chair.
Doctor, I have a brief question. What would it mean? I know some of these terms have popped up while we're doing some of the studying here. What would it mean to put a slow code on a baby that's born alive?
I'm sure, Mr. Chairman and members of the committee, I'm sure that you're all familiar with the concept of a code blue. We've seen enough of these on TV where the patient is having some sort of a medical crisis, whether it be a drop in blood pressure or excessive bleeding or whatever. Gongs go off and everyone in the hospital comes running with all of their equipment, and everybody does everything in their power to resuscitate this patient. That's a code, and a code is not called except in a dire situation. I mean, it's not called just because it's Monday afternoon at 3 o'clock. I mean, it's called for a very specific reason. And the concept of a slow code, as I understand it, and this is a new term for me, but I've done some reading on it. The concept of a slow code is basically, I as your physician, have identified that, you know, things are not going well. Family's sitting over here. Let's, you know, kind of go through the motions and do a half-hearted attempt at resuscitating you to make it look good for the onlookers, okay, and the bystanders. To me, that's incredibly unethical. I mean, if we're talking about do not resuscitate, that's a totally different situation. If we're talking about I'm going to do everything in my power to resuscitate you or your baby, then we do everything in our power to resuscitate you or your baby. We don't put on this little dog and pony show to make ourselves look like we're doing something.
Okay. Representative Parker.
Thank you, Mr. Chair, Dr. Holman. My father was an obstetrician gynecologist for 45 years, and I probably stood at his elbow for as many as I could ever remember. My favorite was the triplets that came in at 23, 24 weeks, weighing less than a pound, or, you know, we were measuring them in kilograms. And so never at any time were they delivered that immediate results of, you know, efforts were made, immediately suction, oxygen, everything was done. And they were as fragile as any infant at any time, and it's amazing how wonderful they did, these triplets. So again, I think the bill is real reasonable on just giving appropriate care in these situations. I don't see any confusing language in the actual text of the bill. It's exactly what is done in all reasonable deliveries of high risk that I've ever seen. Thank you.
Mr. Chairman and members of the committee, God bless you for being the child of an OB. That's not an easy job. My
Okay,
kids will certainly agree.
Members, any further questions of Dr. Holman at this time? Okay, thank you, Doctor.
Thank you very much.
Madam Vice Chair, who do we have in next?
The next one, sir, is, and that is going to be, give me 1 second. We have Ron Johnson.
Ron Johnson.
Thank you, Mr. Chair, members of the committee. For the record, my name is Ron Johnson. I'm the Executive Director for the Arizona Catholic Conference. I represent the Catholic bishops in the state of Arizona, and we're in support of Senate Bill 1600. We believe in the dignity of human life from conception until natural death. Unfortunately, it is often the case that the most vulnerable people are the ones that need the most protection. That is, whether it be the newborn children, disabled people, or the elderly. Often you hear people speak only of the protection of innocent human life from abortions, but this bill applies to all infants born alive. After all, every baby born alive deserves basic medical care and a chance at life. Senate Bill 1600 will make sure premature babies will receive this care and not allow for the killing of a live baby, even by neglect. It is for this reason that we encourage a yes vote on Senate Bill 1600. I'd be happy to answer any questions. Thank you.
Thank you, Mr. Johnson. Members, any questions at this time. Thank you very much, sir. Madam Vice Chair.
Mr. Chairman, we have Kathy Harrod.
Yes, Mrs. Harry.
Mr. Chairman, members of the committee, my name is Kathy Harrod. I'm president of Center for Arizona Policy. Given Senator Shamp being stuck on the Senate floor, I would like to share a story that she was going to share if she was going to be here. And this is from a mother named Nicole Sestaro. I may be pronouncing it wrong. Nicole is the mother of Lorelei Deborah Sestaro Stone. She was born May 3rd of 2022. We have a picture of baby Lorelei. Before the official diagnosis or these are her mother's words. Before the official diagnosis or any abnormalities were seen, we were pressured to abort her. We were told by more than one doctor that termination was the right thing to do. Because of this, we found doctors who promised us they would do everything they could for her. They informed us that Lorelei would eventually need heart repair, but no surgeon in Arizona would operate on her because too many doctors view children with trisomy 18 as not worth the effort or resources, since it will just prolong the inevitable. Lorelei was delivered with no complications. For the first week of her life, we were told she had no issues. She was feeding and gaining weight. On May 10th, they said she would be able to come home within the next few days. Out of nowhere, in the early hours of May 11th, her condition deteriorated. She passed away later that afternoon in our arms. It was a moment that no parent should have to experience. The doctors told us there was nothing they could do. We still don't know if they even tried. Early on, we decided that Lorelei had already fought against every odd. She deserved the chance to continue fighting. It wasn't our place or anyone else's to deny her that chance. We will never regret giving it to her. Lorelei was not a condition or an abnormality. She was not an inconvenience or something to be discarded. Her life mattered. You might want to call this law Lorelei's Law, because Lorelei was not given proper care. Their parents did find out that a slow code was put on Lorelei. This is what this bill is about. Children with trisomy 18, Bella Santorum has lived to at least 15. I think she's 15 now, former U.S. Senator Rick Santorum's daughter. Another woman in Texas has lived to be 40. So we don't know the life expectancy or outcomes of a baby that's born with trisomy 18. To respond to some of the things that have been said today, this bill is about simply ensuring that all babies born alive are given a standard of care, as Representative Parker was pointing out, to take all medically appropriate and reasonable actions. Medically appropriate and reasonable actions are the key parts to this bill. It does update existing law. It's not about abortion. It's about any baby that's born alive. Once that baby is born alive, that baby is a human being deserving of the protection of every law in this country. It's not about conferring personhood on fetuses. Some have been alleging that. Again, it's about babies already born. It's not about giving care to a baby whose death is imminent. It's not about preventing parents from spending those precious moments with a baby born alive and not likely to survive. I would point you to Section E, where it specifically says that the requirements of this section do not prevent an infant's parent or guardian from refusing to give consent to medical treatment that is not medically necessary or reasonable, and that it includes 3 different parts. And it clearly says that if it will do no more than temporarily prolong the act of dying when death is imminent, then their care is not required. So the baby who is born alive, who is not likely to survive for very long, those kind of emergency situations, that baby, the parents will have the time that they need. This is not going to block this. This is not going to make a horrible, tragic situation any worse. That this is simply for the situations when the baby's death is not imminent, to ensure that that baby is given all medically reasonable and necessary care. So with that, I would just close with saying that this is really a win-win situation. This is a win for the parents and it's a win for the baby, and that we want to treat all babies who are born alive with a chance to survive. And with that, I'd be happy to answer any questions.
Members, Representative Shaw.
Thank you, Ms. Harrod, Mr. Chair. Appreciate you coming here. The question really, again, comes to our mind. I think you know where I'm going with this is that if let's say and I did see you reference that section where the parents or guardians can say no and they can decline treatment. The issue is that the section above it goes to talking to law enforcement, any member of that group, and let's say there's a conflict, right, of like, well, we didn't think that it was done exactly properly. Now you're talking about criminal penalties. in the middle of a harrowing situation, that's where the real issue with this bill and the conflict to me comes from. And that's, so I guess my question to you is, what happens when a family at that time said, okay, we're declining, but then somebody says, well, I didn't feel, anybody in the room says, I didn't feel that was up to proper. Now you have a criminal complaint in the middle of a harrowing situation.
Well, Mr. Chairman, Representative Shaw, I would say in that situation, I would say that I would imagine or suppose that you have other emergency room type of situations where that might happen, where there might be one person on the medical team who believes that appropriate care wasn't given and wants to file a complaint, but the person or whoever might have the power of attorney or whatever would say, no, we don't need to do any further treatment. So I don't know that that would be that unusual of a situation. And this is, so I think that's how it would work, that I think that it's not unusual for those kind of situations to appear in other contexts, and so we're just saying that a baby who survives deserves that same kind of care.
Mr. Chair, to follow on, thank you. And I think the difference is that there is a civil component to how we conduct ourselves and what we hold ourselves to as malpractice versus which people can actually do, right? They can sue if they choose to, if they think that the care was substandard. But this is the criminal part, which is where we, as physicians, are really, somebody could be trying to do what they believe to be the right thing and the ethical thing and face a criminal complaint. And that's where, when the criminal part starts to get in place, it becomes a bridge too far. So I guess that's my concern. I'm trying to have you answer.
And Mr. Chairman, Representative Shaw, I would say that a baby's life is worth a criminal penalty, and that I think that there is a need to ensure that this law would be followed, and that a criminal penalty for a baby that's not given care, that is delivered alive, that would be an appropriate penalty, and it would be comparable to other situations, as well as when a baby's not given appropriate care.
Thank you.
Members, any further questions of Mrs. Harrod at this time? Thank you, Mrs. Harrod.
Thank you.
Okay, Madam Vice Chair, who do we have signed in to speak, wishing to speak?
I believe all the rest are if necessaries.
Okay.
Do we have an if necessary? Would you like me to read all those?
No, it's okay. We'll just take them into the record. Members, any further discussion at this time? Okay. Members, the motion before you is that Senate Bill 1600 be returned with a due pass recommendation. Secretary, let's call the roll.
Representative Bliss?
Aye.
Representative Contreras?
Nay.
Representative Gress?
Aye.
Representative Hernandez? No. Representative Mathis?
Nay.
Representative Pinnigarelli?
Aye.
Representative Shaw?
No.
Vice Chairman Parker?
Mr. Chairman, permission to explain my vote?
Please proceed.
Thank you. Again, having had a lot of experience with this and seeing this and hearing the arguments on both sides, the scenario presented that it would induce criminal code. First of all, there is no change there in the criminal code. It's already the same. ARS 362301 also always already requires that appropriate treatment being given, so we're really not making any changes to that. And so having been side by side with this a lot, that scenario that a parent wishes or decisions or wouldn't be part of it and the physician being involved, that could happen with any kind of case and any kind of patient and any kind of, and it rarely does in these settings. And again, if the fetus and the child is not going to live, regardless of all of the heroics and born alive efforts, that child still may not live. If that child is given the respect that every human being should be given, and this statute is all that's asking, and it's just re-enthroning and recodifying what we already have in our law already. It's just adding to that and re-articulating that. It's not as big of a change as I think it's being implied, and with that, I'm a yay.
And Chairman Montenegro?
Aye. Thank you, members. By your votes of 5 ayes, 4 nays, 0 voting present, and 0 absent, you have given a due pass recommendation to Senate Bill 1600.